committee commission meeting. Today's June 5th, 2018, 5 o'clock, or a little after, it looks like about 5:08. We can go ahead and call the meeting to order. Madam Clerk, if we can do a roll call, please.
Commissioners Fahey, here. Hearns,
Present.
Latanzi, Wiley, Vice Chair Fluke,
Here.
Chairman Derryberry.
I'm here as well.
We have a quorum.
All right. Well, it brings us to the part of our program. Do we have anyone here to do the invocation to get on the list this month? No? Do we have anybody to volunteer to do the invocation today? That's fine. We'll go ahead and everyone please stand for the Pledge of Allegiance, though. Flag's here right behind me. Everyone repeat with me. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay.
And I would have volunteered, but I know
you've
reached
already
my quota.
You've reached your quota. And for those of you that wonder why we all didn't volunteer for the invocation, we have a required quota we can't surpass, and so we're going to use those numbers wisely for our own invocation. So, do we have any agenda items to be removed? Public business from the floor. Mr. Paul, we have your card here. Did you want to speak after? Okay, so we have one consent calendar item. We all have received and hopefully reviewed the minutes from our May meeting. I'll entertain a motion to approve them unless we have any necessary changes to those.
I noticed no changes and I move to approve.
Motion by Commissioner Fahey.
I second.
Second by Commissioner Hearns. All those in favor? I'm sure you're all. Today is election day, so here's the first election results of the day, and it passes 4-0. Surprise, surprise. Okay, so we have quite a few people here to present to us today, so we'll get started on that. I had an opportunity to spend some time with our first presenter at the Paraclete Mock Trial program a handful of years ago. His talented son was in the program, so tonight we have Judge Christopher Estes, and it looks like he brought some of his friends as well. So Judge Estes, welcome.
Welcome. I saw on your agenda you had a number of different presenters and different agencies, so I kind of give you a quick summary of what my involvement is in this area of wellness in terms of the courts, and then I will turn it over to questions. But I did ask two of the lawyers that I work with on a regular basis to be here, Mr. John Henderson, who's up front, Mr. Dennis Vincent, who's right behind him. Mr. Henderson is the Deputy Public Defender who's assigned to my court, and Mr. Vincent, right behind him, is the Deputy District Attorney assigned to my court. I am a felony trial court. I've been on the bench since 2001, and run a kind of a strange calendar. 3 days a week I run the prison court, and the fourth day I run a collaborative court, and 5 days a week we now run also the early disposition court. But I'm here to talk primarily about Thursday, which is the Thursday collaborative courts, and actually a number of the other presenters are people that we collaborate with. But we have 3 different programs that are overlap in many ways. We have the Veterans Court program that we run, we have a mental health program that we run, and we also have the drug court program that we run. And I'll just talk to you a little bit about the drug court program, because that seems to be the focus of what you're interested in right now. Anytime someone picks up a criminal case and their case is filed and they come into court, they are assessed first initially by their assigned lawyer, or if they have a privately retained lawyer, to see if it's someone who has a history of substance abuse, or to see if their case is related in some way to drugs and or alcohol. And depending on the public safety factors of that case, the lawyers may meet and confer. For example, Mr. Henderson, who may have the case, he'll look at it and do an assessment. In his mind, this may be a case that should go to drug court. He would then meet and confer with Mr. Vincent. Mr. Vincent is the one who has the authority from the district attorney's office to decide what cases would come into the drug court program. But ultimately, if they come into our drug court program, the goal is, again, is focused on wellness, is to be able to correct the problem, resolve the substance abuse problem, and get them back on track to be not only successful on probation, but successful in life in general. And every case is analyzed on an individual basis because the facts of each case are different, and the individual and their history is different. But we have a general format that we work off of. Most of the people come into drug court will start with an in-custody treatment program, and this is where we're benefiting from the resources that the Sheriff's Department are now putting into their custody facilities. It's called START. Anybody remember what START is? Yeah, he's talking very quietly there, but he knows that's Mr. Price, who is our liaison with Tarzana that we work with every week. But if someone is able to get through the START program, which is the in-custody treatment program, then we transition them back into the community, typically in a treatment plan through Tarzana. It could be residential, but more likely it's going to be outpatient, either intensive outpatient or outpatient. And again, the goal is for them to be successful, to get the necessary help so that they can get back on track. And what's different about our court from a typical case where someone's placed on probation is that we ourselves are the ones who provide the supervision. Probation is not really involved. We are the ones that bring them back in. Tarzana, it kind of provides progress reports as to how they're doing. And then we see, especially drug court clients, are coming in on a monthly basis. And we monitor how they're doing. And anybody knows anything about recovery, there's going to be some ups and there's going to be some downs. And we try to work through those, provide the support when they need it, but also hold them accountable when they need that too. So the drug court program, why don't you both come on up, Mr. Henderson and Mr. Vincent. And if you don't mind, I'd ask them to add their more than 2 cents worth, because actually Mr. Henderson, who despite his youthful look is quite old, he's been around a long time, and he has more time working in a drug court type program. He worked the Prop 36 program that we had for a number of years. But if you've learned anything about our criminal justice system, there have been significant changes in the law, and where simple possession of a lot, heroin, methamphetamine, cocaine, what used to be felonies are now misdemeanors. There's exceptions to that, but that's the general rule. So when someone's facing a misdemeanor, their approach to that misdemeanor may be a little different than their approach would be if they're facing the possibility of state prison. So Proposition 36 is basically, fair to say, has just kind of disappeared.
Yes.
And because there's just not a lot of interest from the defendants, because they'd rather do 180 days in the county jail on a misdemeanor knowing they're going to get out in 18 days, and rather than worry about treatment. So we have to adjust our programs as the law changes and as the defendants adjust to those changes. And so we primarily focus on cases that are felonies. And they're not going to be the more serious type of cases because, as I mentioned earlier, public safety is a big factor in this. You want to expand on that or anything I missed?
The only
Mr.
thing
Vincent?
I'd add is I've been doing this for 25 years, and I'm a trial attorney, actually death penalty attorney for the PD's office. But I also started the drug court down in San Fernando, worked on the Prop 36 court up here for years. And I left for about 9 years. I was working in San Fernando. When I came back, lo and behold, the clients were still here committing the same crimes over and over again. Driving without owner's consent, thefts, felony thefts. And what I did learn real early is you can put them away for a year, of which they'll do a very short time, or 16 months, but they're not cured of the drug problem. And that's what's causing all these crimes. And that what's changed is by getting rid of some of the just simple possessions, we're dealing with the crimes they commit because they're drug addicts, both in the Veterans Court and the drug court and our court, our mentally ill court. And all of them, all those clients are involved in drug treatment because they all have the problem. And it's now over 200 people in those 3 courts that we're dealing with. and we're not seeing them go back and commit the crimes. And incarceration doesn't seem to cure anyone of drug use, but the threat of incarceration does help, and that's what we were able to use. Whereas the old Prop 36, we couldn't put them in custody. Now we actually can threaten them. Okay, if you don't, we'll put you in custody for a while, and he doesn't mind doing it, I'll tell you.
So I've heard.
Yeah, it's true. But it's good. That's one of the components, is not to cure them through jail, but to get them to understand how serious it is and how their life's going to be changed. And then we work with them. They can fail, and he helps pick them up, and we require a lot of things out of them, and it doesn't just end in a month or in 6 months. It goes on for quite a while. So it's the most successful thing we have or have ever had up here right now.
Good evening. My name is Dennis Vincent. I work for the District Attorney's Office. So right off the bat, I have to say that whatever I say here tonight is just my opinion. I'm not speaking for the DA or as a representative of the District Attorney's Office. So one of the things they mentioned was the START program. And the START program, they spend a minimum of 45 days in county jail going to classes and getting into the routine of rehabilitation. And I bring that up because I've been practicing 23 years, and for the first time in my career, I've seen defendants who were out of custody willingly go into custody, or a lot of times unwillingly go into custody so they can have drug treatment. And they come back and they end up thanking the court for putting them in custody. And I've never seen that. And it's remarkable to see. And I've started asking more and more of them, like, what is it that makes it so good? And they're giving us more and more details because, you know, once somebody's out of custody, it's really hard to get them to take a plea or to do anything because they don't want anything to do with going back into custody. So one of the big problems was when the law changed and everything went to misdemeanors, as the judge mentioned, nobody wants treatment. They don't want to put time in jail. And so we've opened up the court in some cases to sales or possession for sales, which is a real dicey subject because technically that shouldn't be allowed. And we don't want to mix the people who are causing the problem with the people with the problem. So the parameters are if there's a clear demonstration that they've had an ongoing long history of drug abuse, and you can tie the sales or possession for sales to maintaining the habit rather than maintaining a lifestyle or just selling because they like money, then we'll make an exception a lot of times. And when I first took over the drug court, there was one participant, and that was somebody with a misdemeanor who was just clinging on. And so once we open it up to these other people, now, as John mentioned, the combined courts, we have over 200 people. So we've had some problems with issues like with the prescription medications, especially the oxycodone, Oxycontin. Things I see are like we had one young lady, she had 7 different identities and she was getting prescriptions from 7 different doctors and going to different pharmacies. And when you started counting up the amount of medicine she was, selling, she was making quite a good amount of money every month. And that's kind of hard to track because almost anyone can pick up her prescription. And at least a couple of years ago, I had done some research, and the database that's supposed to be maintained was only being maintained by a few people, statewide database trying to track who's got what. And then at times we run into the opposite problem where we have a well-intentioned pharmacist who will decide now the law has changed and they've got a little more say in whether or not these prescriptions are handed out. We had one instance where this pharmacist called the doctor's office and spoke to an assistant and got the assistant to agree that, yes, that prescription seemed awfully high, and they decided on their own to reduce that prescription, and she wrote on the prescription, the pharmacist did, and thereby destroying the prescription. And then the individual was supposed to be getting their medicine, wasn't going to get their medicine, and the doctor was going to be out of town. It created this whole big mess. And so, I mean, we have to make sure that the well-intentioned pharmacists with this new law don't go a little crazy too and start hurting people in the process, because if this person runs out of medicine, guess where they're going to go? They're going to go find the heroin, which is the replacement for it. So those are the kind of things we're dealing with. The ARC program is something we came up with on our own up here because we didn't have a different way of dealing with it, and it's wonderful because I won't go into too much detail, but basically we go into the community, the mental health people tell us what the person needs and what's available, and then we can basically put a laser focus on what the treatment is. And they come back like once a month or once every few months, and so we keep a real tight rein on them. And there's always a drug component in these things. So, anyone else?
The only thing I probably should have mentioned, as far as the types of drugs, it's crystal meth, the majority here. It really is. And with the opioids, because they're legal in the prescriptions, we don't see a lot of that. Not that there isn't a problem, but it's crystal meth, it's alcohol, it's cocaine and heroin. Heroin's probably a little above cocaine, but crystal meth by far is the one that we really see all the time and that we're dealing with. And the drug programs could probably talk more about that.
So I think, in short, what I heard is a lot of all the good things that you're doing, but I also heard specifically you're working with a lot of the programs, a few of which are already here today, right? Are there any resources that you're seeing in the courtrooms or with your clients or Mr. Vincent that you're missing that maybe there's somewhere else out there in the community that we can help you find? Is there anything that any gap or hole that you're seeing in any of these cases that we might be able to, note and to be of any assistance to fill?
I think what you just mentioned has been the key to our success is the level of collaboration that we do have. I think a lot of the resources have been in the community on some level for years.
Sure.
But the court has not necessarily connected to those resources in the way that we do now. And we have a Tarzana liaison. We have a DMH liaison. We have a VA liaison that come into our court every Thursday. That way we have a direct connection. And then our liaisons are the ones who are the experts in their respective fields, and then they reach out to the resources and we coordinate. For example, DMH. DMH has a number of contracts under their umbrella. One of them is MHA and Mental Health of America that are here, and we are using MHA with a significant number of our mental health cases that they're receiving their treatment there, and MHA then they're providing the level of care to that individual with the court's oversight to ensure that they're following through. But resources, what are we?
What I add to this is, this all started because these two, absolutely realized this was not being addressed at all a year and a half, 2 years ago. And he contacted Judge Estes at different entities and got them into the jury room and he sat down his phone. And I don't know if you realize this, but no other place in the county has this, what we call the ARC program, and it's dealing with the severely mentally ill. And so it takes a lot of heart. I just heard today my head deputy, because our program is so unbelievable, has now gotten approval to have it moved into the Norwalk courthouse. So they are actually copying the program that was developed in Lancaster.
Great.
And already spreading it over there. I mean, he's met with this a lot and he's been involved with this. And that's just the beginning. They're trying to take what we developed here, the only one that has it, and start spreading it throughout LA County and all the courthouses. We can always use more help, but I think we have the components. We just sometimes need more of those individuals with us, or a little more housing. Housing's always been a problem. So although that seems to be, they're responding to that too. So it's always an ongoing kind of fighting, but it's been doing excellent.
But each of these agencies that are here can probably speak to that more directly in terms of what residential, right? We have residential because we'd love to have more residential beds for people who are transitioning from custody. But before you just drop them off back in the community, it's almost, you don't want to use the word halfway house, but it's kind of that concept where you kind of get them back in the community, but in a much more structured environment with a level of care that's still there. And then we transition them to intensive outpatient or outpatient. But there's all kinds of funding issues and eligibility issues that play a role in this. And sometimes we just had a long discussion with Mr. Price last week about the status of residential beds at Tarzana and the limits or lack thereof. And so there's always a need for more resources, because the one thing that's happened here as our program is built, what do we need? We're going to need more resources. It was when we had 5, 10, 15, 20, it was very easy to find placement. But now we're to the point where we're looking at waiting lists for the different programs. Yes, ma'am.
Is there a magic number that would be required to be for clients to be sent to the drug court? in terms of offenses. I mean, if they have 3 or more offenses that are drug-related, would that apply, or is it the severity of it that would qualify them for the drug court?
I think it's probably all of that. We look, as you know, we get probation reports, and the probation reports set out the criminal history. There's also a component in the report dealing with substance abuse history. Mr. Henderson will talk to family, and he'll talk to other people who may have personal knowledge of this individual, or the law enforcement officers. They'll indicate in their police reports that there not only was there this crime, or there was also paraphernalia. There was a small amount of methamphetamine. Well, that tells us that there's a substance abuse issue. So all those factors play into it, but it's the dialogue between the justice partners, Mr. Vincent, his office, Mr. Henderson and the private bar. It's their dialogue where they meet, confer, and then we have the assessment that's also done by Tarzana. So it's a two-part step. The first step is the district attorney willing to include this case in our drug court? And if they are, then is there a necessity? And I think they may talk about this term medical necessity, which is that the right term? That is the term, and that's the one that's kind of created some angst for all of us. But the medical necessity that there is a substance abuse issue. And if it's yes and yes, then that person will be brought into our program. And again, the one factor I haven't touched on is, do they want this? Because there's no purpose in bringing them into the program if they're not interested in help. I mean, it's not unusual for us to say, hey, we probably can offer you drug court, and he'll turn to Mr. Henderson and say, no, just give me 16 months. Okay? That's someone who's not interested because they're sophisticated enough to know how much time they're actually going to do. They're not interested in treatment. So we're not going to waste our resources on that type of case.
And if they know their sentence is going to be 180 days in county jail, they understand, like in today's language, that means 0 days in jail. They're going to be released that day. So they understand very well what we're up against in that light. And that's why these beds are very important, because for my comfort level, the level of criminal that we're allowing into the program is whether or not they're going to be, an inpatient program or an outpatient program, because, obviously we don't want to put someone on a 45-day treatment and then just put them back on the street if they have a high level of criminality. And so we take a chance in a lot of these cases, but, I'm very strict about the rules that we have. We have the same thing with theft crimes. We've allowed some theft crimes like, joyriding and vehicle thefts, if, again, we can tie it back to their addiction. And we had one yesterday where the lawyer wasn't paying attention, but it didn't look like it had anything to do. The guy had stolen a car, and then he got out of jail and stole another car. And I talked to the defendant's mother, and she said, well, we're homeless because of his drugs, and he keeps stealing cars, so we have somewhere, because she had like 7 grandchildren that she's trying to house. And so this guy's out stealing cars because he can't get a job because of his drug addiction, and so to put the family in somewhere at night. So there is a connection, and the guy's never going to get better unless we, get him into a program and get some treatment for him.
And
So.
what I would say is, I might not know how to spell methamphetamine, but I know what something's on it. And some of these reports don't show anything at first, but when he reads the report, when I read the report, we know immediately there's a drug problem here, and it might not even be mentioned in there. And they'll recommend a lot of times, this doesn't look right. And we'll read, yeah, there is something. Then I go and I start finding the information about what is going on here, because it clearly involves drugs. So the DA helps so much. They send them up there, even if it's not right there in black and white. You can tell there's something going on. Now, sometimes it could be a mental health problem, but we deal with that too. So it doesn't matter. We know it's something. This is not right. This is not normal. So it's a teamwork.
And the one issue we do have is there's categories that just we don't allow into drug court or into veterans court, and that's like arsonists or child molesters or registered sex offenders. So some of those people have mental health problems. A lot of them have drug problems. So that's where we're kind of at a loss. And I don't know how to address that necessarily, because a lot of times they just end up going to jail because we have nothing else available for them.
For the dual diagnosis type of client who has the mental health and the substance abuse.
Right, but if they have a prior conviction or are charged with one of the crimes that, technically nobody with a strike offense or a strike prior is eligible for the program, but we make exceptions. And then that's where we, in my office, we do kind of an internal review of their history and, what the crime is here and what the victims think about it. And we'll make exceptions all the time. But there's certain crimes like arson we just don't make exceptions for. And I think some of the programs they will not take them. So what do we do with those people? And that's just...
To follow up when you mentioned, though, START, the in-custody treatment program, they are expanding their pods. And what I mean by pods is their housing facilities within the county jail. They now have a dual diagnosis pod for males.
Okay.
And we're hoping that as it continues to expand, that they'll be able to open a pod for the females, because we're seeing the same type of issues.
And the mental health cases, they're always dual diagnosis, co-occurring disorder. They all are. So I don't think we've had a single mental health case where it didn't involve the drugs component. And a lot of times it starts in the dual diagnosis program before they move into it. So our biggest problem is with this medically necessary, and they're in custody for 60 days. So they're clean. So all of a sudden, have you been clean? How long have you been clean? 60 days. Well, they can be residential. They're clean. That was one of the things we came up with. I'm wondering if they were in a coma for 6 months. Are they magically not needing a bed? So we've got to go through that and work with them. Tarzana treatment's been wonderful. All these work with Project 180, and North America.
MHA.
They're really good. But those are the stumbling blocks we have trying to...
We always need to find a funding source for a lot of the programs, because that's how these programs exist.
One of the things that did come up when we were discussing this prior to you all being here, and thank you guys so much for your time, but when you have repeat offenders, is there anything that you all can do as a court to say, okay, we're mandating you to do X, Y, and Z, as opposed to a choice of theirs to say, I want to participate, or no, I don't want to?
Well, I think, see, that's kind of a tough question, because you're saying you must do treatment. Well, you could talk to the agencies here, and I think, and they can correct me if I'm wrong, but they're going to tell you that that's not the mindset that is going to, of someone who's going to make a change. So when I say we give them a choice, I say, you could do drug treatment in these parameters, and I go over those parameters with them, or you could say no, and then your case is going to move on through the system. And so that's the decision. That's where they're empowered to say, okay, let me hold on here. What are my options, and what should I do? And they get into it sometimes. They think, oh, this really isn't for me. But not that often. Usually once they get in the process and they realize, wow, there are other people like me. There are other people dealing with the same issues. I'm not that unusual, all that strange, and there are people who are successful. And here's the beauty of our Thursday court. We have people in all different stages of the process. So they see people who are finishing and graduating, and then there's people that are starting, so they can watch the process and realize, wow, they've done it, they've gotten through, they've been successful. They hear the liaison talking about the progress and the good things that the people are doing at Tarzana, and then I think it helps them buy into the program.
And there are people who get into the program because they're just trying to get out of trouble. They have no interest in actually being cured, and those are the ones that I think get fleshed out eventually, because it is hard work, and they're coming back and forth to court, and there is somebody with the thumb on them at all times saying, you didn't do this, you didn't do that. So eventually those people will kind of burn out, and it'll become obvious who they are after a while.
But we don't have many. These are people, when I came back after 10 years, I'm watching these clients that have been arrested 10 times in between and have gone to prison sentence over and over again. And some of those we pulled into this. And as far as the mental health court, I think we've had one person that failed and we might have been able to work with, but he just felt it was better. He wanted to move out of state and took his time. But generally, they're still in that program. I mean, we're setting these people on 5 years felony probation. We're dealing with them for 5 years. The drug court's a little shorter, but you don't have them coming back again and again anymore. And these are people that I knew in 94 and 95 and helped them several times, but not with drug court, because we didn't have it. We didn't have any of these things. And it's totally different. They're seeing, we're not going to cure them. We're not going to, you slap the crazy out of someone. If we're mentally ill, we have to treat them and we have to work with them because they're going to live with this forever. And the same with drug addicts. You are a drug addict forever. You're an alcoholic forever. You don't know that. You're not going to get better. You can't ever walk away saying, "Hey, I'm going to be fine." So that's what we try to instill in them right from the beginning. It really works almost all the time right now for us. Not that they won't start to pick up another drug case after we for long, then they'll start thinking I'm cured. But we're there then to take them back in, put them back through that into jail, make them go through the program, work with them until they realize this is not how they want to live their lives.
But one of the other things, I was in private practice for 10 years before joining the DA's office 13 years ago, so I've seen both sides. And drug addicts can make up the most complicated lies you've ever can imagine. But we don't put up with those lies in that court. But one of the problems we've always had is somebody, they're good while they're on their medicine. You know, they have mental health issues. And then they start feeling good, they stop taking their medicine, and you can't convince them otherwise. What has come along in the meantime is now we have injectables, where part of their probation condition will be they have to report to a doctor, say once a week or once a month, and take this injectable medicine. And if they don't appear or refuse to take the medicine, then the doctor reports them, and we know right away that they're now off the program. And they don't have that time to build up, you know, to degenerate and start committing more crimes, hopefully. So we know right away. And that's a huge comfort level for someone in my position because it's always the same. It's like they're great when they're on their medicine, and then they feel good and they go out and do something really stupid or hurt somebody. So the injectables have been a great thing, and having this close supervision of them, it allows us to do that. So.
How many do we have in each one of the courts? Do you guys keep a tally of the active?
Well, you know, they come and go a little bit. Some people graduate. Right now, I would say we have 65 to 70 in the mental health courts. We have, I'd say, about the same 65 in the drug court. And again, 2 years ago when we started, there was one person in the drug court. And then veterans, it's probably about 50 to 60 also, maybe a little more than that. And we do it all in the same courtroom because they come in saying, we think it's this, and then all of a sudden, instead of veterans court, it's a combination of veterans court and
Sure.
mental health court. And we'll move them from one to the other as we see it's necessary. We're giving them the life treatment.
What's nice is that that's when you have the liaisons there with their expertise, they actually are cross-networking themselves. We don't always even know it. He may know it, but I don't necessarily always know it. And then all of a sudden, Mr. Price will come out and say, "Hey, I talked to Ms. Bryant from DMH, and we think this is where we're at." And they both assess, they both interview the defendant, and it's a beautiful thing to see. And because they're already knowing what we're trying to do, they're coming up with a treatment plan, and then the question, you know, so I'm ready. All I have to do is implement, and the work's being done, rather than sitting and waiting and trying to look around. Who out there can do something here and making phone calls? It's all right there.
You know how it used to be done, like when I was a defense attorney and until very recently, a defense attorney would say, "Hey, my client's got a problem, I need a program." And the DA would say, "Well, you know, we're looking for like a year in jail." And, you know, I would come back and say, "Well, how about if I find you a year program?" "Okay, find me a year program." And it could be anything. It could be mental health, just, you know, go home and pet your cat and hum for a month and come back and that's your program. And now, with the Department of Mental Health looking into their past and interviewing people and interviewing the defendant and just fine-tuning the program, it's now just, it's so much, I can't believe we used to do it any differently because this just works so much better because now we're actually identifying the real problem and treating the real problem, not just trying to, you know, keep them busy for a year. So,
Great.
and it's no picnic either. So, I mean, they're really working hard. And
Got a lot of presenters still to come. So
Yeah.
unless there's anything else, thank you all for letting us have an opportunity.
No, thank you for your presentation, gentlemen. Thanks for all your hard work. Okay, so our next presenter here is from LA County Department of Public Health. I think we have Anton Moore, right? Come on down.
I'm coming.
I think you brought some friends with you too.
I did.
Perfect.
Thank you so much for this opportunity. So my name is Anton Moore, and I am the Chief Marketing and Beneficiary Engagement for our Strategic and Network Development Unit at the Substance Abuse Prevention and Control. And with me, I have Yanira Lima, who is the Chief of the Adult Systems of Care for Substance Abuse Prevention and Control, and Dr. Tina Kim, who is the Chief of our Health Outcomes and Data Analytics Unit within SAPSI. So we're all going to be presenting on different things, if you'll allow us. So I am going to start probably with Dr. Kim, who will just share some of the data that we have, if that's all right with you. And then I'll go a little bit into our system of care and maybe address some of the questions that might exist around medical necessity and how to enter our system of care. I'm so grateful that we have the judge and DA's office and Tarzana Treatment Center here as well. So I will let Tina start. We do have some handouts. What's the best way to give them to you?
You can bring them up.
Okay.
Oh, I guess there's maybe hand them to the clerk or Ms. Brubaker. I forgot there's the velvet ropes in front of us.
Thank you. My name is Tina Kim, and as she introduced, I'm overseeing our health outcomes data analytics for LA County Substance Abuse Prevention and Control, any surveillance related to drug and alcohol and our other substance use issues. But I didn't know exactly what kind of data you were interested, so I brought some of the data specifically for SPA 1, since we have all raw data available, and we did analysis, in-house, and then brought all this one related to substance use prevalence in SPA 1, and then hospitalizations, ED visits related to substance abuse in SPA 1, and then mortality rate compared to LA County and all other ones in SPA 1, and then treatment admissions among this SPA 1 population. But I'm not sure how detail you want to go over. I can just sum up, and then you can refer this one. And didn't know the purpose of it. What is the best way to go? I'm honored to be here, by the way. But I was requesting a lot of, like SPA 1, that we need the data. We need the data. Even if you look at the national NSDUH, National Substance Use, survey, drug use and health, and SPA 1 and SPA 5 are combined because sample size is too small. It's so hard to get the prevalence in SPA 1, but luckily we had community needs assessment we did throughout LA County, and then we had almost 10,000 data collected, and then we had a SPA 1 data prevalence available. So it's all included. I can go over, but do you want to go over each area? Or we can you guys can refer this one.
I'm sure we, we'll refer to it. If you could, maybe just give us a summary.
Yes.
What are we dealing with up here as it relates to the, our drug epidemic or issues? So a summary would be fine.
Perfect. So in terms of prevalence compared to all other LA counties, SPA 1 is higher, in particular among those young adults, 18 to 25. Even overall prevalence is really high. And then if you look at the community needs assessment we did, it is amazingly high. The same way national found that 38% of 18 to 24 in SPA 1 reported that they have explored, cannabis. Especially we did a community needs assessment, cannabis and prescription drug. So thus prevalence is really high. And treatment admissions among 18 to 25 young adult is really high as well. And then if you look at even hospitalizations, ED visits, so it's increasing with the age. The highest one, hospitalizations, ED visits associated with substance abuse, alcohol and other drugs. In SPA 1, it's increasing with the age, and then 45 to 54, the highest one, 26%. And pretty much all other areas, SPA 1 is the highest compared to or LA County. When you look at the community needs assessment, data prevalence, if you look at it, and if you look at it, their perception of perceived access of cannabis or prescription drugs on the street around their neighborhood, their overall percentages are higher compared to LA County, which is actually predicting of their prevalence, which is higher in SPA 1. And so they perceive it's 85% of the people who utilize the prescription drugs or cannabis at least, they say that it was easy for them to get either cannabis or prescriptions on the street around their neighborhood. So it is their perception of risk and then perception of availability of access around the community was really high, and because of that, prevalence was really high. Even though the treatment admission is a little declining, it's consistent with our LA County overall data, but I think it has a still need, and then we estimated that about 3,000 in SPA 1 based on the utilization assessment that needed to be treated, for substance use disorder, but right now about 1,700 are reaching out, accessing to the treatment services. So that's a pretty much overall summary of what we included in the data. So if you have any questions, you can, contact us. But I think Anton and Yanira will go over about accessing all these treatment services. Thank you.
Perfect. Thank you, Dr. Kim.
Bless you.
Thank you, Dr. Kim. Okay, and we also have some brochures. Let's see if I have enough. I think we have enough, yeah. So I hope we're not overly paper-driven for you. But what I wanted to share is kind of as a starting point is this is the brochure that we're currently using to outreach to a variety of different organizations, managed care plans, DMH, DHS, Department of Mental Health, Department of Health Services. And so I felt like it was a good starting point to share a little bit about our program, what we call the START ODS, or the Drug Medi-Cal Organized Delivery System, has really offered an opportunity for us to expand services provided to people who need substance use disorder treatment. So what it does is it expanded the approved services that can be funded under Drug Medi-Cal and allowed for hopefully greater access as we move into our second year of implementation. We actually implemented this in July 1st, 2017, and we have increased eligibility actually changed eligibility for our services. Prior to July 1st, we had eligibility requirements under Drug Medi-Cal, but the Drug Medi-Cal system was limited to only 2 or 3 levels of care. And so this new service allows for us to expand that to incorporate a number of services. So first, let me start off by sharing a little bit about who is eligible for our services. Those folks are eligible if they are eligible for Medi-Cal. So they either are signed up or eligible to be under Medi-Cal. The same thing is true for My Health LA, which is people, either they're eligible or they are on My Health LA. We will accept either one. And if they are a part of our drug court or AB 109 program, they are also eligible for our services. One of the words I kept hearing as our distinguished presenters prior to us was about medical necessity. So I thought I'd share a little bit about what medical necessity is under our system. Medical necessity means that someone enters our system, they say that maybe they need or they know someone who needs treatment services. We will do what's called an American Society of Addiction Medicine assessment or screening. and that will provide us with information on their level of care and their treatment needs. That might be outpatient, it might be residential, it might be intensive outpatient. I'll go a little bit into that. But what happens is that either someone will enter our system through what we call our substance abuse services hotline or helpline, through our client engagement and navigation services, or directly to one of our treatment providers like Tarzana Treatment Center. The substance abuse services hotline is a number that someone can call. They will get a live person who will talk with them, do a brief screening to assess whether they do meet medical necessity, also to see if they are eligible for Medi-Cal, MyHealthLA, or one of the other county programs. And then they will make a referral to a provider of their choice or in proximity to them. It is a 24/7 line. They can call anytime. And so that's one of the ways they can enter our system. I'm going to let Yanira talk a little bit about the client engagement and navigation.
Well, good afternoon. Thank you again for allowing us to come here and provide you with information on the services that, of course, as a department we provide. And I think before I go into the services provided by the client engagement and navigation services, I think the main thing that we would like for all of you to take away from our talk and our presentation is the great opportunity that has been made available to the county as a response of the Drug Medi-Cal organized delivery system. And I say that because previously to July 1st, although we have 10 adult drug court programs throughout the county, they were very funding specific. So, and by that I mean that they were provided with maybe $200,000 or $300,000 a year. With the introduction of Drug Medi-Cal, there are much more funding that's available, many different services that in the past were not available to the population. So when we talk about opportunity, I think that we need to really look at that opportunity and take advantage of it. In reference to the SENS, or the Client Engagement Navigation Services, it is a coordinated entryway. We have now about 56 co-locations throughout the county. It's dedicated really according to service planning areas. They provide outreach and engagement, screening and referral, follow-up, and they connect individuals to benefits. So it's another one of our entryways, and Tarzana, of course, is one of our SENS providers here in the Service Planning Area 1.
And then, of course, there's directly to the provider, which I already talked about. With that, once they are referred to a provider, what happens is that they typically do a warm handoff. What that means is that they will talk with the provider over the phone, make sure that they've got an appointment prior to the client getting off the phone, typically, and then they'll be referred. Once they actually attend the appointment, they enter into our system, and a full assessment will be conducted to see which level of care that they would be eligible for. So there are several levels of care. If you don't mind, I'll just go into them very briefly. Outpatient is one of them. I think you've heard a little bit about some of these. Outpatient is a less intensive, community-based level of care. It's a maximum of 9 hours for adults, 6 hours for youth. It includes group counseling modalities, individual counseling, patient education. It includes a new benefit under this system, which is case management benefit, which allows providers to help coordinate care with other agencies, allows them to provide services that may not be directly related to substance use treatment, but might help in looking at a whole person, an integrated way of providing services. There's crisis assistance. And so these are the services that are available under the outpatient. Intensive outpatient is also an outpatient model. It is a more intensive program. It's up to 19 hours per week, or 30 hours per week for perinatal. So those women who are pregnant or parenting have access to more hours of treatment. Like any managed care benefit package, there is some limits for the intensive outpatient in terms of the hours. The same thing is true for the outpatient. Similar to outpatient, there's group counseling, individual counseling, case management, patient education, family therapy, and crisis assistance. We also have our withdrawal management program. It's a detox, what most people know as detox, and that is available. Most of the time, our benefit package prior to July 1st, it was primarily a medically monitored detox program where people went in for residential. They stayed there for a period of time until they were ready to move into the next level of care. This benefit package has expanded withdrawal management to include both ambulatory, which means it's outpatient withdrawal management, as well as residential withdrawal management. And so these services are with or without medication, and it's limited to 14 days. Our residential services are, as the name implies, it's a residential modality, and it is a short term and includes all of the same services as outpatient, including case management. It is what we call a pre-authorized service. So what that means is that providers who have assessed a client entering their system as needing residential would need to submit a request to provide residential services, and our quality improvement and utilization management team would review that information and either approve or not approve residential services based on medical necessity. So that is an authorized service. That service is available to patients for 180 days. In the past, under the state, it was only 2 times a year that they would have access to residential services, but the county has opted to expand that when there is medical necessity or a need for those services. Medication-assisted treatment and opioid treatment programs. Both of those are sort of a medication model in which patients would come in for services and receive medication that would help them move through recovery, in addition to outpatient counseling or residential if they need. I'm going to hand the mic over to Yanira so she can share with you a little bit about recovery support services, which is an entirely new model, and recovery bridge housing.
Right. And maybe this is something for those that were in the past involved with the Proposition 36 program. We used to have a benefit under Prop 36 that we refer to as aftercare. So once an individual completed treatment services, whether it was residential, stepping down into outpatient counseling services, they would have at least 6 months to participate in a outpatient program, or aftercare program. So the same idea of the aftercare program has now translated into recovery support services. So once an individual completes outpatient or residential or even withdrawal management services, they have an opportunity to receive recovery support services. They could be within a treatment provider. It's not specifically treatment. It's mostly receiving, say, individual or group, or just doing more like relapse prevention. So once an individual could stay there up to a maximum of 2 years, but every 6 months would have to receive Medi-Cal verification at the very least and continue to meet medical necessity. Another very exciting benefit is recovery bridge housing. And I think for a lot of us, recovery bridge housing, we would refer to it as sober living. So the county, as part of the Measure H, received, or at least our department received $6.2 million to really contract for 500 beds dedicated throughout the county for Recovery Bridge housing. One of the benefits for Recovery Bridge housing is that it has to be connected to outpatient counseling or intensive outpatient counseling services. However, it adds, say, another housing option for individuals that potentially might not qualify for residential treatment services, or individuals that are in residential treatment and step down into outpatient connected to Recovery Bridge housing. The benefit is that an individual will receive up to 180 days in Recovery Bridge housing. So I think that's a very exciting benefit. I think it expands and addresses some of the issues with the homeless situation that the county is experiencing.
So I think that's all we have to share, but we're open to sharing more through questions that you might have.
So I have one question. As far as the available services in your updated pamphlet, are these all available here in the Antelope Valley, accessible and available, or are there any gaps maybe here locally within the city or the Antelope Valley, as far as you can tell?
Well, as far as we know, yes, I think Tarzana happens to be one of our programs within the county that has the full continuum of services, everything from the client engagement navigation entry system all the way to recovery support services. So they are, I think, one of the biggest programs that we have within the county. And starting even with withdrawal management, they have that benefit all the way down to even Recovery Bridge housing.
Great.
And then there's also our Antelope Valley Rehabilitation Center, which is the directly operated county facility.
I'm not familiar. Where is the county facility?
That's in Acton.
The active facility.
Yeah,
Okay,
exactly.
that's right.
It's not in Lancaster.
That's right.
Right. And I think you might also have on this handout, I don't know if you have it here or not, Anton, but we have a service bed availability tool that's web-based, and really any individual, whether the public or a provider, can access that website, and it provides you information as where services are available within the county. It offers you the total number of beds that might be available in residential, as well as potential openings for outpatient counseling services. So it's web-based. It's very easy to navigate. I don't know if the address is on here or not.
It is.
It is, yeah. So that's an actual benefit that was also added as part of the expansion of the Drug Medi-Cal Organized Delivery System.
It's actually located under How to Find Services.
There it is.
Yeah.
Yeah.
I was just wondering, it sounds like you do wonderful work, and just thank you so much for reaching out and working to reach out even more to help people who need it. The 500 beds that you were describing via the Proposition H funding, do you have a sense of how that allotment is going to be, or what might be coming to the Antelope Valley, maybe?
Yeah, based on the last numbers that I was reviewing last week, I think Tarzana, and maybe Tarzana could say yes or no to this, but I think they have close to 90 Recovery Bridge housing beds. 5 beds?
Sorry, 5 houses.
Right, but total beds, maybe about 70 to 90, you would say. So you would have about 70 or 90 beds allocated to SPA 1. The hope with Recovery Bridge housing, at least for the county, although 500 are specifically paid for by Measure H, we have other funding sources that we are currently looking at and trying to see if we could repurpose some of those funds so we could potentially expand up to 1,000 beds countywide. And hopefully then, the assessments would be done to ensure that there's sufficient capacity really distributed across the county, including SPA 1.
One of the things we do recognize is that there just are not enough residential treatment facilities or beds that are available. I think that was articulated earlier. And this is one of the ways that we can kind of help bridge that gap, is that while someone is either exiting incarceration, they have access potentially to a recovery bridge housing bed, as well as receiving dedicated treatment, either outpatient or intensive outpatient.
Great. Ladies, thank you.
Thank you.
Thank you.
So I think our next presenter really needs no introduction. Judy Cooperberg from Mental Health America, whose hair is much shorter today than it was Saturday night, Judy.
Oh, yes,
Judy was at our LPAC gala on Saturday, 70s themed. She looked wonderful and had hair past her, almost to her waist, I think.
Yeah, I went as me in college.
Okay. Well, you looked fabulous, so welcome.
Thank you. So I'm Judy Cooperberg. I am the Chief Advancement Officer for Mental Health America for North County, and I'm here with my colleague, John Glover. So we're going to do our little dog and pony show here. For those who don't know, MHA's been in the Antelope Valley since 1988. Our chapter in LA County has been around since 1924, but I wasn't there. When we started services in the Antelope Valley, the only adult mental health service was a very small county clinic. And as we identified more and more unmet needs in the Antelope Valley, we really had to advocate to get funding up here because no one really cared. So we really even had to advocate with our own organization because our organization was based in LA and Long Beach. So there was really literally a desert of services here. I did want to, before I forget about this, we were talking about the forensics, and I think, Angela, you brought up about forced treatment. MHA philosophically and in practice, it's contrary to what we do and how we view recovery. We don't find that helpful, and it's not effective for people who are dealing with mental health issues, and it hasn't been proven to be effective. Lora's Law was passed in the state of California, also known as AOT, Assisted Outpatient Treatment, and the Board of Supervisors did pass that in LA County, and some agencies have been willing to contract to provide AOT. MHA is not one of those. Like I said, the recovery model that we follow is that we are looking at hope, empowerment, self-responsibility, and meaningful roles. And that's driven by individuals' desires and working with people on their own service plans and what they want out of life. That tends to be more successful because we're not telling people how to live their lives. We're asking them, how do you want to live your life? What are your goals? What are the barriers to their goals? And how can we overcome those barriers? So that's what we're working on. A large percentage of the people that we serve and our primary target population are people with severe and persistent mental illnesses, and a large percentage of those do have dual diagnosis, substance abuse issues. Not all of our services are mental health services. Our veterans program, Military Resource Center in Palmdale now, serves the entire Antelope Valley, and also in Newhall, that is for veterans and their families who are homeless or at risk of being homeless, mental health issues or not. And that's a contract with the Department of Veterans Affairs. I was just informed that MHA will be receiving approximately 30 slots of forensic full-service partnership. Full-service partnership is funded through the State Mental Health Services Act. So the majority of the mental health services in the state of California, and LA County has the biggest part of that pie, is through MHSA. And the focus is on full-service partnerships, and it's very intensive case management services. So MHA is the primary FSP provider in the Antelope Valley with, I think, how many do we have?
170 now and about to expand.
Yeah. So, we're getting another 155 in the Antelope Valley. It's still not enough. In comparison, Long Beach has about 1,600 compared to we're approaching 265. So there's still a lot more advocacy to do. I serve on the LA County Mental Health Commission and for 6.5 years, and I'm the squeaky wheel there because no one cared about the Antelope Valley. And we were able to get them here twice already, and the psychiatric urgent care is a part of that advocacy as well. So that has been funded in the Antelope Valley, still working on a site, and that's been awarded to Star Behavioral Health. So that's going to be a huge help. The Sheriff's Department is very excited about that, and we're hoping that gets built really fast. We do also focus on transition age youth, 18 to 25-year-olds, and those are those kids, a lot of them are aging out of foster youth. And when Public Health was talking about the increase in substance abuse between 18 and 25-year-olds, I can guarantee you a large number of those are coming out of the foster care system. We have a high incidence of homelessness with that population, substance abuse, exploitation of the girls, kidnapping of the young ladies, and that's why we've had a concerted focus on transition age youth since 1996. So we like to say that MHA is a Get a Life program, so we're focusing on people's employment, housing, education, and overall well-being. So we are looking at the whole person. We have a number of homeless programs, a lot of outreach, and John is actually in charge of our HOPE team, and he's going to talk a little bit about that.
Good evening, Commissioners, and thank you very much for having us. I'm a licensed clinical social worker and a team leader with Mental Health America, and I've been with the agency for over 10 years, 13 years or something like that. It's a pleasure to be here tonight. Very happy to be here with the other providers in our community and with Judge Estes and the court system. I really believe that we're coming into a time where collaboration is going to affect some significant change in our community, and I'm really glad that the city of Lancaster's, spearheading that and joining us in that. So as the discussion's about substance abuse, but it's not that simple, right? It's, as we've talked about co-occurring disorders, it's actually much more faceted than that. Homelessness, substance abuse, criminology, mental health conditions, domestic violence, we could really have quite an in-depth discussion around how that all plays together. Almost no one we serve is purely one category or another, And so just like I think one of Judge Estes' guests mentioned, we discover more about the complexity of someone's life the longer we work with them. And it's almost always a matter of looking at the different pieces of that puzzle that represent a person's life, most of which comes out of trauma. A lot of the people that we serve have been from broken homes and early childhood experiences that are, that inform that trauma. And they perpetuate that into their adult years because they don't have anything else to lean on. They don't have a big brother, big sister to teach them different, and we become that. We become the people who say, let's help you get a life. But what life do you want? So substance abuse is often a response to trauma and a way to navigate struggles with mental illness. Methamphetamine was mentioned, and while abuse of methamphetamine goes well beyond what I'm about to say, many of the people that we serve at Mental Health America use substances like methamphetamine to cope with the realities of their existence. If they're homeless and they might be assaulted at night, they use meth to stay awake, and then they sleep during the daytime. If they have mania, methamphetamine actually acts to calm them down, as we discovered in treatment of attention deficit hyperactivity disorder. So the difficulty with that, and I happen to be a person who has both a mental health diagnosis and a substance abuse history, is you can use something thinking that it's helping you, and then you cross a line and it becomes your second or your third problem. And then you don't know how to get back out of that. And so what we've realized is we need to approach people from all those different angles as best we can. So in various teams at Mental Health America, we have embedded substance abuse counselors. We have embedded domestic violence counsel staff. We have embedded nurses, for instance. And we find that approach, that multidisciplinary approach, is really effective. We are very, very happy with the work that the court's doing with Judge Estes and the mental health court, et cetera, because we have seen just remarkable turnaround. I agree. People who go through that part of the court system do not have the same recidivism as the general population. And from my own story, I can tell you that if I were offered help, even if I didn't really want it, once sobriety kicks in and stability kicks in, it's pretty sweet. And then people decide they want more of that. But if you don't have anything to lean on, if nothing replaces your substance abuse, if nothing replaces the struggle you have with your mental illness, then it's all you have to go back to, and that's why we see recidivism. I think criminology is a consequence of that much more than it is a causative factor, right? But the impact on our society is huge. We're happy to be doing the work we're doing. Substance abuse is not our forte. It's something that we, with Tarzana Treatment Center's help and many other agencies, we found ways to collaboratively address what the public's going through. So we're open to any questions you might have. I'm happy to be here.
And it's probably hard to quantify, but how often are you seeing, percentage-wise or numbers-wise, the dual, diagnosis or classification, substance abuse, the mental health diagnosis as well? How often are we seeing that? Is there a percentage? Can you quantify it for us?
So I can make a blanket statement that while many people may not have a diagnosable substance abuse condition, in other words, they're socially using, right? Or they're using periodically, and I couldn't go so far as to say, this is an outright diagnosis. It's rare that we find someone who has never used and used in a way that was about coping with what they're going through. So in other words, it's not recreational. It might feel that way, they might describe it that way, but when you dig a little deeper, you find that they use it to cope with or numb out or get by something that they're struggling with. I would say we serve at any given time 600-700 people. Because we also have a drop-in center. We've got people who aren't technically enrolled in anything. We don't turn anybody away. So we have a high volume of people that come in.
About 7,000 a year come through our doors.
Yeah. That's not, so those are individual people, not repeat visitors. Of those, 80%, and that's probably a lowball figure about that dual diagnosis.
Well, the reason I asked was because a few months ago we had the emergency department as well as Dr. Gurian from Allen Valley Hospital from their psych department as well come and speak. And so they kind of said the same thing. That's why I wanted to ask you was, what are you seeing, when you're getting your patients and your clients through your doors as opposed to what they're seeing coming through the emergency department, whether it comes on a hold, because oftentimes, the stories that they told is oftentimes they come in the door and they're being assessed by the emergency department. The ED does not know whether or not it's a mental health issue or if it's a substance abuse issue or both. So anyways, that's why I asked that question. So
I think we have to assume that it's all present.
Sure.
And we used to try to treat people one issue at a time. And so while you're busy helping with domestic violence, substance abuse becomes rampant. and they sink further down instead of coming out of it. We've realized that we have to approach, as I said before, we have to approach people with everything we've got and address everything that they're willing to go. And some things they're not yet ready to address. But at least if we can help them with the things they are willing to look at, then we have, we plant seeds towards improvement over time. And so we work with people for a long period of time. Some of our individuals in full service partnership can be with us 3, 4, 5 years. And then they may enter into less intensive programs and stay with us a few more. And it does take that kind of time to treat both the mental health and the concurrent or conjoint conditions that they have. But we see great success when we're given the space and time to do that.
And you can see that at our Golden Bell Awards on Wednesday, October 17th at 4 p.m. at the fairgrounds.
And you're all invited.
Perfect. Thank you. Thank you so much. Thank you very much.
Thank you.
Thank you.
Okay, next up, we have our last presenters for the night from Tarzana Treatment Center. And I don't know all of your names. I think one of you is Alicia.
I'm Alicia.
Alicia, sorry.
I am the program director for the 10th Street programs.
Welcome.
And I'm Joshua Price. I'm the substance use counselor, and as mentioned before, I'm the liaison to the Lancaster Drug Court.
And I don't have a prepared speech for you all. This was very kind of last minute, but apparently I don't need to because Public Health so graciously covered everything that we provide here in Lancaster.
You're welcome.
So in terms of our services, it is the full spectrum, including primary care clinics. We have one, about one building down from this building, and we have a clinic also in Palmdale. We have our residential program and our outpatient program, primarily on 10th Street, but we are opening a new clinic in Palmdale, primary care, which will also include additional outpatient SUD services, along with some mental health services as well. We have 5 of the recovery bridge houses that we spoke about earlier, which are a wonderful component of our treatment program. Our only issue there is that it's sometimes difficult to actually obtain the houses. Nobody wants to rent to someone that they think is going to provide treatment. As it was called previously, sober living, they get a bad rap if someone's running one of those houses that is not overseeing it, where people are not in treatment, that sort of thing. So it makes it a bit of a challenge for us, but we keep persevering, and we did recently, our 5th house just opened recently, and we were immediately able to fill the beds right away. So there is definitely a need. With our adult residential program, we have 40 beds, and we are full all the time. If we have someone that is leaving, it's a planned discharge. We have somebody already scheduled to take that bed, which is sometimes a difficulty with the court because we aren't able to save beds for someone because we have so many people waiting for the beds that we do have available. We have youth programs. I'll throw that out there too. Same modalities where we have residential, outpatient programs. We have substance use disorder programs and mental health. We have a large mental health contract also. We have a wraparound program, if you're familiar with wraparound. And that about sums it up. Do you have any questions?
So how long is your waiting list for residential?
Well,
here in
the way it works is that we try to get people a bed if they need a bed anywhere. So it might not be through us. It might be through AVRC. It might be with one of our other locations, which could be Long Beach. Some people don't want to go to Long Beach. So that can be a barrier. So I don't really have a specific time to tell you in terms of a waiting list. It's a pretty fluid situation. I will say too, though, that if we do think that someone might have to wait, we do try to get them into our intensive outpatient level of care. We really try to work with the person that that's, you know, better than not having anything at the moment.
So I know generally in business, it's never good to talk about who else is out there. And I think my hat's off to Tarzana because everyone talks about all the things that Tarzana does. Who else is providing the services in the Antelope Valley? I mean, obviously we know MHA, but with respect to some of these, you know, the services that you provide for the drug treatment programs and that sort of thing, is there anybody else that's out there?
There are other providers, probably not to the extent that we provide. Penny Lane is another provider up here. In regards to residential beds, I believe it's just us and Acton.
When you say Acton, the county facility in Acton.
AVRC.
Oh, that's right, AVRC, that was what I was going to ask.
A part of our initial focus has been the methamphetamine situation, and just would you have a couple of comments on your current view or experiences with that particular agent and the Antelope Valley and your experience?
Well, I can tell you firsthand that I've recently done 5 intakes personally and entered data where the primary substance was methamphetamine. So, I mean, that's just recently in the past 7 days. So, I work a lot with the youth too, so that's a large problem with youth, along with cannabis use disorder, severe. Josh is more working with the adults, so he sees a little different picture than I do. You want to go ahead?
Yeah, I'll go ahead and add to that. I would say probably 85 to 90% of our clients coming in at the 18 and above age are coming in for methamphetamine use. And 9 times out of 10, I'm sorry? I would estimate it at 85 to 90%. Followed up by alcohol, and then probably cannabis. So those are probably the top 3 that we are seeing out here. And then this goes back to that chicken or the egg concept that's been batted around by MHA and DPS. How much is substance use? How much is mental health? I mean, you are taking methamphetamine and you are up for days at a time. At some point, the brain cognitively starts to shut down. Hallucination starts setting in. You know, you add malnourishment into that mix. You add inclement weather, and you're looking at a perfect storm. So the question is it substance use? Is it mental health? Well, oftentimes the two are intrinsically tied, and it's a matter of taking this knot and trying to undo it slowly. And as they mentioned, taking an intrinsic whole person approach to try to unravel it. Is it simple trauma? Is it complex trauma? Is it trauma that started in childhood and has been exacerbated by substance use? Sometimes it's all of the above. And one of the great things about our program is the fact that we can provide a full continuum of care, whether it's through physical health, which is something we're required through Medi-Cal. They have 90 days to get a physical. We are connecting them to a medical doctor. They are getting a physical at the very least so that they're getting checked out, because for some of these people it's been years since they've actually been seen by a medical doctor. We can connect them to mental health, whether it's, you know, putting in a referral to Mental Health America or Department of Mental Health, or even internally within our own program, so that we can start dealing with that trauma. We can start dealing with, you know, these bipolar symptoms that we're seeing. That, well, is it the methamphetamine use, or is there something else underlying that's been there all along that you've been attempting to mask? We can deal with the anxiety. We can deal with the depression. And then we can also tackle that homelessness front through Recovery Bridge housing. We know through statistics that the longer people are in treatment, the longer they get care, the better their outcome is going to be. And so through the courts, and through everything, if they meet that medical necessity, and unfortunately that is the threshold that we are limited by, but if they meet that threshold, then we can have them 16 to 90 days in residential, followed by up to 6 months in intensive outpatient, followed by another 3 months in outpatient, followed by recovery support services. And that's ideal. That gives us a good year and a half of monitoring them and slowly transitioning them back into the community. But it all depends back to that medical necessity. One problem that we have seen and one that we have been confronted with is an issue of housing. We can get them into our Recovery Bridge housing facilities, but after that 90 days is up, then what? And oftentimes we're attempting to assist them as much as we can, connecting them to Valley Oasis or connecting them to other resources. But this goes back to how much does the client want? How much are they willing to seek? I've had clients that had appointments at Valley Oasis, and then we had a bed open up, got them in, said, well, okay, did you follow up with Valley Oasis? Because again, this is only short term, this is 90 days. No, I'll wait till it comes up. At that point, we're now limited by the client and the amount of energy and effort they're willing to put in. So there is a fine line that we are towing, but we do the best with what we can.
Yeah. Anybody else have any questions for Tarzana? Of course.
All of the programs are talking about getting Medi-Cal funding. What about the people out there that aren't on a Medi-Cal level?
Great question.
That are that are drug abusers or alcohol? Where are they left? Just to go to their normal doctor, or we have a population out there
We provide services for anyone. So we have folks that have Kaiser insurance, folks that have Blue Shield insurance, folks that have Medi-Cal insurance.
And is that the same for public health, or are you just limited to Medi-Cal?
Medi-Cal, I have LA.
Okay. Right.
And again, all clients, we assess them at intake, and if they do not have Medi-Cal, we can accept them if they are Medi-Cal eligible under a presumptive status, which will cover up to 90 days.
Sure.
So we are, and during that time, during those 90 days, our goal is to get them enrolled in Medi-Cal so that they actually have access to all of those benefits as well.
Now, one thing, I did have one final question. Go ahead. Did you have something?
I have a different.
Okay, I have a slightly small question, I think, so Commissioner Fluke might beat me. So I'll let her go last. So you made a comment, and I think you, in a way, you did it in passing. It was more so something having to do with the trouble you have with getting the houses. Can you maybe touch on that a little bit? Is it actually getting the houses themselves? Are you renting the houses? Are you buying the houses? Is it getting a license? Is it just blowback from the neighbors when they find out you're coming, or is it all of the above?
I think it's renting that we deal with. Primarily, it's management companies of houses that we'll look at. But I mean, I don't know what to say other than my personal experience with it has been for a few houses that we've looked at. As soon as they find out it's Tarzana is paying the rent payment, oh no. It's like no, we're not doing that. So that is, I think, a barrier.
So Tarzana itself doesn't own the homes; they're just renting the homes to do the in-house. Okay, that was what I had. Go ahead.
So it's kind of a question to everybody. I've known of several situations, and it's kind of the unraveling of is this dual diagnosis, or is this the addiction with these other mental health diagnoses coming to people, that people have been admitted through 72-hour holds and things like that, and after several of them, they've come out with 5 very heavy, big mental health diagnoses with other medications to help with that, whether it be anxiety, bipolar, schizophrenia, personality disorder, anxiety, that then have all this medication that then goes along with that. And then the addiction part kind of with it. So how can we fix the system to kind of, it's the $1 million question, right? Like, how do we fix the system, from the courts to all these wonderful providers that are, faced with this on a daily basis, that our community members are going and getting these diagnoses and being put on these extreme medications, and then, trying to get them off of meth or heroin and things like that, but they're still so medicated. How do you unravel that with so much medication being prescribed just from doctors as well? It's just...
I think it's a very complicated question. When you say, too, about other doctors prescribing, that is an issue if not all parties are talking together. So one party doesn't know what the other party is prescribing. I think one benefit for Tarzana, I think we're our own little niche, is that our prescribing doctors are well aware of the abuse that can happen with medications. I feel like we probably have less of that issue of overprescribing medications, but yeah, I think it's a really complicated issue, and I don't know if you wanted to speak to it too. But,
So I think that we have to make a distinction at this point between stabilization services that happen in emergency departments, for instance, or on psychiatric short-term units like Antelope Valley Hospital has, and long-term rehabilitation treatment, long-term recovery services. So when a person goes into a psychiatric program, so an inpatient psychiatric setting on a 5150, so to speak, their treatment approach is stabilization. It's, in a way, it's behavior modification. It's not focused on the long-term well-being of that person necessarily, because their intention is to get them in and out. Beds are very expensive in those programs. When they're released, the type of medication that they've been prescribed, which is very sedative, it causes people to be, right? That's not the person we want to treat. We need someone who can think for themselves, and so we tend to then immediately try to decrease the number of medications and look at medication interventions that allow for functioning, so they can make decisions and take actions. And you'll see that then that drops off. I think that it would be really helpful, and I think with the mental health urgent care coming on board, the sooner we get that, it's been 3-4 years while we've been trying to navigate this. I think we really need to make that happen. If we have ways to help people without the inpatient psychiatric treatment, except when absolutely necessary, we'll find that people are able to get into long-term recovery. I love it that you can work with people for 1.5 years. I didn't have that opportunity.
Yeah, best case
right,
scenario.
I understand, right? And people don't want to stay with us any longer than they have to either. There's another, I just wanted to make a little comment about something I heard earlier too. Yes, people will decide not to take their medication when they start to feel better. Recently, that was identified as an actual symptom of illness, not just a choice. So I get all these bulletins about psychiatric findings. I wanted to bring it out right now because I think it's important to understand that just like we wouldn't criticize a person for hearing voices, right? When they're feeling well, but part of their illness is that they believe wellness means they don't need the care anymore, they'll make choices that cut themselves off from care. Now that we have that identified as a symptom, we can treat it that way instead of looking at it, right? So when we talk about that long-term process of recovery, that type of thing usually happens 6-8 months out, at a point when sometimes we're no longer actually doing intensive services. If we can keep a person in engaged services for longer than that, when those kind of roadblocks come up, we're actively involved with them, and we can intervene and we can help them through that. So we usually see that at a point when a person's already in such a low level of care, we're maybe only checking in with them every couple of months, right? And And so I think the same thing will happen in the criminal justice system, is that you're at that latter stage of treatment, and suddenly they're well, and the symptom of, and I'm sorry I can't remember the name of it, but it's got a really cool name, that comes up. So I think what we really need to look at is long-term care, keep people out of emergency rooms. It's expensive, it's not actually conducive to long-term recovery, and we have some programs coming on
So
board.
it's more like crisis intervention when
And
it's
it's
in the
needed,
ER.
Commissioner, it is needed, but I think we could decrease the amount of that significantly, right? It's just that people don't have anywhere else to turn to, or they've learned that the emergency department is their doctor. And we need to change that perception among the people that we serve. A lot of the Measure H funding that's coming is helping to address that. So some of the programs that we have at Mental Health America, for instance, part of the programming that I supervise actually looks at finding homeless people who are mentally ill or using substances, getting them connected to a myriad of programming that will help them, and then staying with them long enough to make sure it lasts. Last thing I'd like to say, it's a little off topic of this, but housing is a huge issue. I've heard it come up from every one of the different groups that presented. And it's not that we don't have scattered site housing that maybe the ideal person could go into, but what we really need are those dedicated supportive housing and what did you call it? Transitional housing. We'd see much greater success. But I do understand that there is a lot of community stigma and NIMBYism, and it is a hard thing to do, but there's money to make it happen through Measure H. So we're at a really pivotal time here where I think we can make it happen. Anyway, thank you.
I got a way out of the box question. And I hear you, and I hear that about the money and the funding and the wonderful resource that you guys all provide to the courthouse and so on and so forth. Would it not make sense, and I'm just kind of one of these way outside thinkers, how about if they built the facility, or you took the funding and had a facility where you all were kind of housed together with the people, where they could come there and receive all the sources? Because what I'm hearing is that I can do A, but you can't do B. He can do J, but you can't do K, because it's housing or it's funding, whatever. And, I don't want you in my neighborhood, but, I want the help. And then I got to stay here a long time, but I can't stay here a long time because the next person, because I'm thinking, where's the endless road of these people coming into and going out of? Is that so far-fetched? Does that sound too crazy where you would just build when Antelope Valley got a lot of good land, that's open, not next to nobody, but you could build it up where it would look real. You could have a judge in the courthouse there where it could all be processed there, but I still feel like a human because we want to treat the people with dignity and some sustainability of life. And would that make sense of some sort?
As part of a broader spectrum of recovery, so that's a piece, not the sole. Not everybody's going to be willing to do that.
I understand.
Right? And so we always have to find ways, one of the difficulties is we only have this or this to offer. Like I heard that from the criminal justice system and the court system. There's not a whole lot of latitude. And I understand there's reason for that, so it's not a complaint at all. But out in the public domain, we have a lot more options. We can create them. So I don't disagree at all. I just see that as that fits kind of in a continuum of care. And I know that Lancaster is working on something similar to that right now.
Well, yeah, I mean, and not to make it so sterile, like the old mental hospitals and stuff like this, but, I live here, and you hate to leave because you're doing really well, but, what the point about it is I'm getting well. I get well, and I can walk out as a good person or a new person, not as I'm still locked up into it, so.
I can tell you for Tarzana is looking at ways to expand our residential beds. So we are looking into how to do that.
There's also a model called Housing First.
Yeah.
There's also a model called Housing First, and that model incorporates housing someone first, and then including in there wraparound services where they receive substance use services, they receive mental health services, they receive all of those services within the facility. It's a model that has worked. I know Measure H funds are also going toward increasing permanent supportive housing.
Okay.
That's what it's called, permanent supportive housing. And so that might be an option.
The MIP program that is one of the programs that I supervise at Mental Health America. It's multidisciplinary integrated team through Department of Mental Health. Sorry to throw a bunch of acronyms at you, but it is a housing
We were already
first
confused,
model.
don't worry.
It is a housing first model. However, you have to have the housing to make that work.
Right.
So we're a long way from where we could be with these wonderful funding and opportunities that we have. If we had housing that we could place someone into within 24 hours, that's the ideal for housing first. Then you wrap all the services around and you do all the assessments and you figure it out. Because one of the things we know is it's Maslow's hierarchy. If people don't feel safe, they can't take on the rest of it. And safety is a roof over your head, even if someone else is cooking for you at first, right? Or making sure you get to your medical appointments. But if you don't have that, like we have many people who walk into Mental Health America, and I'm sure in other programs, that say, I just want a cup of soup, right? And we say, yeah, that's great. We'll get to, and we'd love to get you housed too. And it goes right by them because that is just not where they're at. But we feed them a cup of soup a couple of days a week. We go find them out in the desert, right? Which we do. And we get to know them, and one day they say, what about that housing? Right? Because they're starting to feel safe and supported, and there's some structure coming in. But housing first, I'm 100% on board. If we can only make the infrastructure has to be there to make that work.
And that can happen either through a scattered site or through just one location where everyone, if both models
or
work.
a mix of all that would be really great.
I wanted to respond to your comments about having one building with all the services in it. I've been around a long time, and I've experienced that in varying degrees. When we first started up here, we were co-located with the Department of Mental Health. And what happens is you've got very different cultures between the LA County Department of Mental Health, for example, and Mental Health America, and the way we practice. And there was a lot of problems with that. When we did the Homeless Solutions Access Center, starting in 2000, it was supposed to have all these agencies and they're working together, just like what you were describing. And there was a lot of this. And depending on who was running the program, there was this culture clash. So we found that it hasn't really worked very well. When we proposed the Access Center, which did get funded through NASA, and we went to San Fernando Valley to a program that was similar because we were researching this, they said, oh no, you can't do that. You can't have all these agencies under one roof. And we said, wait, we're the Antelope Valley. We're highly collaborative. We always have been because we've had to be. We can do this. It didn't work. But we are very collaborative, and we're finding very creative ways, like the court, that has all the different agencies coming in, and we found that this is how it really does work. So that's just my opinion.
I mean, I see that as like, you know what, if it's a one-stop shop, you can't do everything, but if my neighbor can, why wouldn't? I mean, I understand the bickering, but I just see it as a very positive, because we're talking about the whole person. We're not talking about what you can do. We're talking about how this person gets helped, and I think
I would just want to reiterate, we do, we work well together in the Antelope Valley in terms of referring to other providers. If we don't have what that person needs, we immediately refer to one of our.
I mean, so it could work. It just kind of finding the right group of people.
You know why you don't want the agencies housed together, but we do a lot of co-location.
Yeah, that.
Well, I you know what? I guess in my own mind, I'm saying, okay, if it's not next door, but see, like if you had this huge facility and you're on the north side and somebody's on the south side, you're not housed together, but you in a close enough proximity that you're not going here and there, because the person in the middle, that housing area, they would be the people where they would be housed there, receiving the services. I guess is how I'm picturing it. Like not necessarily in the same building where you got to knock heads, but on opposite ends of it. I mean, you're doing it now. It's just that we're in Antelope Valley and you're on 10th Street, you're on West Street, And so, I don't know. It's one of those outside the box thoughts I had.
I invite you to come visit us and then go to some of the other facilities and see that there's, so we have a drop-in center. If our drop-in center was even at the other end of the building with other providers, I think there could be some issues there because some of the folks that are coming into a drop-in center are not ready for what Tarzana is offering.
Okay.
And we've got people at risk over on the Tarzana end who are now watching, hey, I know you from the street, right? So I think that co-locating has worked, you know, and we talk about it all the time, and we do it to some degree. I'm a little concerned about the idea that all the providers just become housed in one spot.
Okay.
I think that is likely to have,
Issues.
likely to be dysfunctional.
Okay.
Sure.
Especially if you have county, county DMHs, they have metal detectors. We don't have metal detectors.
Yeah, that's true.
Because that's not our culture.
Yeah. Okay.
Thank you,
Thanks.
guys.
And
Thank
so,
you so
again, it's just as a continuum. I'm not saying no to it. I just think that it's just a piece of a much bigger spectrum of services we want to provide. Because if we can meet people where they're at, not everybody's there, and they're not here, and they're not here, but somebody's with them.
Okay.
Thank you.
Thanks.
Thank you.
Thank you guys so much.
Great.
So commissioners, where do we go? Where do we go next?
Well, I'm just wondering how we can help advocate for the mental health urgent care, because I know Judy and I've talked about it and tried to look at space, like try to find spaces, and it's just, we have, it's just like Measure H. We have funding for this community, which we always complain that we don't have, and now we can't find a place for it. So how can we, as a commission, help to, push that along so that we can have that? Because I truly believe also that would have a huge impact on the community.
So for those of us that don't know, Michelle, can you tell us what you're talking about?
So there's funding already approved for this community to bring up an urgent care for mental health. So instead of people having to go to the emergency room, they would be sent to this 23.59 second urgent care for psychiatric urgent care, and there they would be able to be assessed, treated, and placed, hopefully, in appropriate services in the community. So right now, they go to the emergency room, and they sit there for however long until they can get them assessed and into the 72-hour psychiatric hold, or
they sit in the ER.
services. Yeah, or they sit in the ER. And
Can I answer that?
yes,
Okay. So it's even better than that. Because they're actually going to, we do not have any child or adolescent services, psychiatric inpatient services here. They're planning on doing.
Who's they, Judy?
Okay, Star Behavioral Health has received the contract from the Department of Mental Health to create a psychiatric urgent care. And they're already doing this, I believe, in Long Beach, and they have another one somewhere else in the county. So it's a 23-hour, 59-minute program that diverts people from the emergency room at the hospital. Then they have to place the folks somewhere else after those 23 hours. So another piece of this is that they've been funded for a crisis residential program. I believe it's up to 90 days. So that's the other glitch in this, is citing the crisis residential program. And it's really critical to have both of those up and running at the same time. They're also going to have a portion of the psych urgent care serving adolescents for the first time in the Antelope Valley.
When is this due to start?
they need a spot.
They need a site.
So it's just,
2 sites.
okay, so the theoretical program is already in place on paper, I guess,
They have a contract.
and funded.
With no land, with no building.
And what's the drawback to identifying land or space here?
They did identify space on the AV hospital campus to build the psych urgent care, However, the hospital doesn't want the crisis residential on the campus. So from what I understand, that's where the glitch is. And I haven't spoken to Star Behavioral Health for a little while, so I don't know where they're at with that, but it's still being held up.
So it's partway there, and the AV hospital complex have said, we'll reach out to you and shake your hand a little bit, but we just can't embrace you all the way because of this residential part of the picture. And so we've been hearing from each one of our presenters that it's the housing,
Right.
it's the beds, it's that's where a lot of assistance might be needed. And I don't know if our commission could help promote that aspect of it, the housing, and not the land, but the housing, the beds, and the other piece being the housing, the beds, the urgent care, which I'm just going, oh, wow.
For the homelessness, we already have a commission, which is the Homeless Impact Commission, which is doing the homeless, no, Kensington is mine. Okay, so Scott's project's my project. Homelessness is her issue. So is this homelessness, or is this going to be strictly drugs?
Well,
No,
psychiatric.
Mental health.
Psychiatric would be this commission.
Yeah.
Which would also
Okay.
Address the substance abuse, because a lot of it is
Okay.
the dual diagnosis.
Okay,
It all
got it.
dovetails together.
How many beds are they looking
The
for?
crisis residential is I think it's 18 beds.
I think it might be helpful to figure out what are some of the viable options in terms of where we would house this place. Because, as we drive throughout the Antelope Valley, we've got all these vacancies and boarded up places. And it's like, gosh, there are just multiple needs that could possibly be met if we would kind of tease through and comb through what our options are. So that might be a place to start.
And try to focus on the collaborative model with however it is we reach out. But I see housing being, the beds being, I think, one item we just might want to say there's something solid here for our commission. And the other piece being, thinking of prior presenters, would be the prevention piece, the education piece. So I sort of see like a two-prong approach, possibly, that we need to figure out how do we pull it together, and where is our thrust.
So do we pull together, who else do we need to speak with from the community? Or
Housing or some facet of it.
Our department does housing, so that's the city in terms of what you're discussing. And what you're discussing is a lot of the vacant, boarded up buildings that you see. Those people are not, we have beat down their doors. They are not going to cooperate with providing residential housing. And I think all of the providers, such as Penny Lane, Tarzana, and some others, we've probably dealt with most of the property owners of the vacant buildings. There are not a lot of vacant homes. Those have been, the foreclosure market, it's very minimal. The ones that you see that are boarded up, there are issues with the property owners, and they are owned by people who have issues that might be dealing with mental health, might be dealing in the court. Those are the people that we're dealing with that have those vacant homes.
Well, I'm not even speaking of homes per se. I'm speaking of anything that could be, used. Yeah.
Well, the buildings would be, other buildings you're talking about are industrial and commercial, and they are zoned, and they cannot be used for residential. That's one of the difficulties. Now, when you get to the vacant land, we've gone through all of the vacant land as to what can be done based on the general plan and zoning. So what it takes is, it takes a developer, it takes money, it takes a lot to get to the housing That's why there is a shortage of affordable housing. That is why there's a shortage of housing for these types of uses, not just in Lancaster. It's a statewide problem, and it is reaching an enormous amount of attention because the development cost for the developers to develop this type of properties is off the chart. And the city of Lancaster has nothing to do with that component because we are extremely customer friendly. We work with anybody who comes through the door that wants to do that kind of project. So we're not the difficulty. A lot of it is the environmental review process, but that's not our process. We're doing, even with Scott's project, with the different funding sources, the environmental clearances, we still are going through problems, and the city's already followed the NEPA process, the environmental assessment process, and we're still, I don't know, going through that with them to give them the mechanism to fund the project. So the housing is quite complex, and it's not that easy, and I don't know if it's something you want to tackle in terms of getting the housing, because it's actually going to be more like going to your legislators to get things changed in terms of the environmental process and other things that all the developers have to go through.
But you know what? Even this was helpful, just to hear what you just shared. You know, because like I said, as I'm driving and seeing things board up, and even this place on Yucca that was the old skating ring, and it's, you know, down the way from what used to be the homeless shelter, you know, it's like, why not?
Because that guy, I can tell you
That
for
guy
a fact.
won't sell for
Yeah, and
cheap.
he wants a ton of money
Yes,
for that
he
piece of
does.
property because I'm doing what I do 9 to 5. I know that a lot about that property.
But I'm just saying that it was helpful to hear
We've
the truth behind
we've had
these
to deal
things.
with him a lot. He doesn't live in the area,
No,
and
got 310 as zip area code. You know.
yeah, because we would have loved to have done something to improve that area. And I don't know what he'll ever do with the skating rink. I mean, maybe it'll be like some of the houses I saw where they just eventually collapse.
Well, you brought up, you said something that a group that we haven't spoken to. What if we invite our local legislators or somebody from their office to come speak at our next meeting about these topics? Very generally speaking, you know, I had lunch with Tom Lackey towards the beginning of his most recent term, and I know he and Scott Wilk are very receptive to these sorts of issues and what we're facing. Let's have a why don't we have a conversation with them? I mean, we're not going to solve this, and this is our third substantive meeting with conversations with the community. And I mean, why don't we reach out to their offices? I mean, if we want, why don't we just start with the local California legislators, between Scott Wilk and Tom Lackey's offices, and I mean, maybe save Steve Knight's office for another meeting, but just start with those two. Explain what we've heard from our stakeholders. Explain what we've heard. Talk about maybe some of the things, and they might know some some bills or proposals that are before them in Sacramento that might affect us or help us. So why don't we try?
And I just have one other question. Do the 18 beds have to be in its own facility, or can they be carved out of an existing program that has some housing, or something that's currently being built for something like that, like Kensington or something that, just those 18 beds for this purpose that they're held aside? Is that a possibility that we don't have to build a whole new facility or look for another whole facility?
I went to San Francisco to visit an organization, Progress Foundation, that has different models, psychiatric urgent care and crisis residential. So the agencies actually have, they can design it the way they want. So if they want it attached to the psych urgent care, they can. They could have it a mile away or 10 miles away if they want. So it's how they design it, so they have a lot of leeway with that. I just know that psych urgent care has to be close to a hospital because people have to be screened medically.
Well, it seems like, and the urgent care might be taking care of it, seems like it's just this other piece of it. Is that
Yeah.
true? So I'm just wondering with like what Tarzana's doing and what the city's doing and what you're already doing with your, with your housing behind your facility, like is there any way we could carve out, like so that there's always the 18 beds for the urgent care to be able to refer into?
You couldn't do it in an apartment.
Okay.
Because it's a very structured program.
Okay.
It's a very intensive crisis residential program. So, no, you wouldn't do it in apartments.
Okay.
Do you want to?
I believe that group was working with Vern, were they not, in trying to find a place? Yeah. They spent months. At one time, they
Yeah,
looked at
it's
the
been
old
a while.
library, which they're rehabbing now. They looked at the old Kmart building. They
I
looked
think
at
the old
everything.
Starwood they looked at.
Yeah, they looked at every single one of them, and they made some offers, and I don't know where they are now. You know, you can have them give me a call, and I can find out.
Well, I wouldn't be opposed to hearing
Maybe
from
that's
them.
a step that they could.
Yeah, they can give me a call, and I'll find out what's going on.
Well, let's reach out to those offices for next meeting and continue to think and brainstorm.
Do you want to do both of those in one meeting, or should we dedicate legislation to one meeting and then?
Right. Yeah. No. Let's do the legislators in July, and then I thought I understood that Ms. Brubaker's office is going to try to have a conversation with Starr, not particular to our commission, and if the conversation leads to something I think would be beneficial to have a conversation here, then we can invite Starr to speak with us. So I don't want to get too far ahead of them. You know, let's maybe if your office can speak to them with what they're facing. Yes.
Absolutely.
Thank you.
I don't think we need to do
I
it
mean,
here.
and if I learn something, I can email it out.
Yeah, that would be perfect. Okay. Okay. Any more discussion on in our next meetings? Please.
Doesn't have to do with housing, but I've been sitting here, one of our big problems is they made everything misdemeanors, all the drug cases, and so nobody wants to go into custody. And I was thinking that there used to be at least a diversion program where the judge basically has carte blanche to do whatever he wants and over whatever time he wants, or she, and then it results in a dismissal. And it occurred to me with all these different providers here that we might be able to create our own little program where the court could mandate some of these people that are arrested for drugs to go through this outpatient, out-of-custody program. And a while back, we had tried to create our own diversion program, and we'd use City Hall, and we were actually on the verge of introducing it when different legislation came along and made it, not worthwhile. But it occurs to me that this drug thing could be the perfect thing because you've got a lot of very anxious people out here that want to help, and the people who are facing misdemeanors, they're not doing anything. They're not getting any treatment. They're just basically doing some minimal task or, so that might be something that you guys could, you're the perfect forum for it because you've got access to all these people. And I know Tom Lackey, he likes to have roundtables that I've been to a few of them with involving different things in the community too, especially when it involves law enforcement, things like that. So
Sure.
I just threw it out there. So.
That was ideal.
Perfect.
That's what I was saying. Thank you.
Yeah, there's a judge, Gorovich basically would be in charge of the misdemeanors, but if you wanted to, I could get a hold of him and have him contact somebody here if he's interested in coming to one of your meetings or if you wanted to. So just let me know.
Sure. David Paul. See, last meeting you spoke at the beginning because you had somewhere to go, and then now tonight's meeting is 2 hours. I will say I need to drop my ballot off, so we need to get out.
Yeah. Mr. Chairman and Commissioners, good evening. Tonight there was another meeting like that about parks or something, and I didn't go to that because I thought that this was more important. And I want to thank you all for the information tonight. This was very informative, and I appreciate, that's the first thing I want to say is how much everyone is trying to solve these problems. You talked about trauma before, and I know that undiagnosed head injuries are a major factor in a lot of these things. And if I ever die, I would like my brain to be cut open to see the CTE. You can't even see that, but I have been hit in the head so many times in my life in fights and different things, falls, that I know what's wrong with me, but I deal with it by having a purpose in life, by meditating, by exercising, by helping my community. These are the only things that help a person get over anything and get a sense of self-sufficiency. So thank you for all you do. And I also don't want us to be unaware of the political climate we're in. I called this sense WUD, World Unraveling Dissociative Disorder, and that is a thing that affects people that just can't figure out what's happening to our country. So these are compounding problems, and it doesn't make it any easier. The problems keep getting worse, and I appreciate what you do. That's why I come to learn what's available. There's a lot of great ideas, and then there's CEQA regulations and things like that that are hard to get around. So, but we're working at it, and I appreciate that, and I appreciate you all for what you do. Not many people would do this, and I love this community for the wealth of people we have that will come here and try and make a difference. Thank you all.
Thank you, David.
Thank you.
Okay, does any of the commissioners have any more comments tonight? No?
Go vote.
Go, yeah. Well, I voted. I didn't mail it in time, and I got to go. We got to drop the ballot off. Anyways, well, we'll go ahead and adjourn. It looks like it's about 7:13, and Commissioner Wiley did join us for the purposes of the meeting to make sure we got him showing up late. So, anyways, well, our next meeting is July 3rd, 5 p.m.
I will not be here July 3rd.
Okay. Are we gonna? I know it's the day before the 4th. Are we gonna have an issue with getting a quorum? Okay, if we're gonna have an issue getting a quorum, make sure we notify city staff beforehand so we can, either table it or cancel it. Anyway, so we're adjourned. Thank you.